For those of you who don't know me, I'm Pat McGauly. I'm one of the emergency department staff here. And I'm going to talk a little bit about drowning, near drowning, or as a bunch of folks you'll see in just a minute got together in Amsterdam, that it's all drowning. Whether you survive it or not survive it, it's just drowning. So now you're not going to work. Hey.
Hey.
Oh,
Sorry, there's a competing conference, and this was our fault.
Oh, that's no biggie.
There's a nursing conference.
How are you?
Good.
Not a problem.
These guys probably all know you, so.
Pretty much. I know most everybody here. So I want to start off with a case, and fortunately the staff and residents that were involved in this case aren't here. This actually came to us not long ago. But it was a 16-month-old male who was flown in by a very reputable air crew and was found face down in a bathtub. And it's almost like reading the epitome of the pediatric drowning case. Somebody read it right off a script. But mom said she left him for just a minute. And when she came back, he was face down in the water, okay, in a bathtub. Just a little bit of water. And she called EMS. EMS was able to get the child to breathing spontaneously with just a nasal trumpet and a bag valve mask. Now, en route, the patient had a seizure. The air crew gave some Ativan, and the seizure went away. On report over the radio to us, there was a GCS of 14 because the child was slightly somnolent. Respiratory rate, heart rate, you can see right there at face value, okay, not too bad. But they said there's some kind of posturing movement en route, okay? Not sure if that was a seizure, whether it was actual posturing. Then they said, well, the pupils are kind of poorly reactive. So, at this point, they have our attention. And then at presentation, things were totally different. There was some form of decorticate posturing. Could have been seizure, but it looked way more like posturing. Eyes were closed. SATs were 87%. Respiratory rate had gone up. So the GCS, at this point is low. Heart rate's up there, and there's some clear frothy sputum at the mouth. Okay? So I want you to remember this case. Going on to definition, the International Congress on Drowning in 2002 attempted to put some consensus as to what a drowning was. They made the statement that a drowning is a process, primary respiratory impairment from submersion in liquid medium, okay? What they didn't say was that you have to have an interface, okay, between your airway and the surface or your breathing. In other words, fancy way of saying you have to have some water in between your breathing oxygen, okay, to be able to drown. But they didn't say that. So by definition, any person who has sustained an immersed in liquid and had any respiratory event drowned. And so that's been kind of a tough thing to swallow in the States anyway, because you have people that drown. And what's the first thing you think of if someone said somebody drowned? That they're dead, okay? But that's not the case internationally. So, American Heart, with a research group led by Ulstein, gave us a little bit more physiologic definition. This is the one we generally use. Now, the International does not recognize near drowning, but American Heart does. Okay, so you have submersion in a liquid or immersion in a liquid after a period of asphyxia, okay, or no oxygen, secondary laryngospasm. And as you'll see as we go on, that's the mechanism of drowning. So you have a more physiologic and common sense definition, and then near drowning, obviously you survive, at least for a while, because very frequently, as I just found out Dr. Green had already given a lecture to this to the pediatric faculty not too long ago, you know, that they survive at least for a while until fluid shifts occur and other things, and that's where the real morbidity, mortality, and the art of managing the drowning victims comes in. So the scope of the issue, and I was kind of flummoxed. I grew up swimming and I grew up diving, and at 6 months old, I was one of those YMCA babies they threw in the water in the 60s, and I survived. Maybe not.
I was just going to mention, I think you hit a really important point that I was going to hope to emphasize from the next step in the critical care perspective is, you know, the way that I usually ask the question is, would you rather have freshwater drowning or saltwater drowning? And the answer is unequivocally is saltwater drowning. Freshwater drowning, the problem is that even a small amount of fresh water that gets into the alveoli will actually remove the surfactant and cause irreversible atelectasis or lung collapse, or not necessarily irreversible, but it's
well, it is. It's scarring, and it doesn't go away.
It's really hard to get them open. Once that's happened, it's the model used in animals to reproduce ARDS, and so that's that late issue that he's talking about that is so important. And so a key question when they come in is, where were they? Were they brackish? Was it fresh? And because that would tell you a lot about their likelihood of survival.
And that's very true. But as I was going into as well, I had no idea how frequently people drown. You have near drowning. Some I saw some as low as many as 10 times, some as many as 100 times. For every person that drowns, there's 10 or 100 that near drowned or had some event that they didn't even report. And remember, worldwide, some of the most populous countries, if you will, are on the coast and don't report deaths like we do. So it may be way more than the 500,000 that's reported deaths. You can extrapolate many more that have gone into an emergency department somewhere for some form of resuscitation. And then this is the one that I had no idea about. But you have 3,000 deaths in just the United States alone. And think about that, how many, that's just shy of what? 9 or 8 or 9 a day. Would never have thought that. But it's that prevalent here. And if you're going to end up, and why drowning is important to surgeons, if you're going to end up in an area, and even not so much along a coast, because a lot of drownings in rural areas are in freshwater streams, ponds, and other things. But where it dovetails into you is that the people who are involved in drownings very frequently have been involved in trauma beforehand. A boat runs over them, they dive into the water. How many times have you heard that one? Where someone dove into the water and, well, you know, we had one just the other day with a cord syndrome. They were putzing around at Lake Claiborne, I believe, which is north of here, and had a few beers, you know, and dove into the water from her boat, and it just wasn't as deep as she thought. Okay? And this is somebody, you know, who was highly educated, who was a professional, I never would have thought would do something like that. But the issue is that you don't know how deep that water is. So where the trauma comes in is that very frequently there's trauma involved and the drowning is secondary to the trauma. So that's where you're going to get involved and have to manage both. And plus here, when we call a drowning comes in, it's pretty much a trauma stat. So you're going to see it. All right. Scope of the issue, it's the third leading cause of unintentional injuries. You can't comment on the case because you were part of it. Unintentional injuries, 7% of all injury-related deaths are drowning or have to do with drowning. Second leading cause of death in children. Okay? I had no idea because I would see some, but I'm, at one place. But when you look at the scope throughout the United States, it's a very prevalent issue. The long-term scopes of issue is a third of the survivors are going to have some kind of major neurological sequelae of some sort, either cognitive deficit, either neurological deficit of some sort, motor deficit, sensory deficits. They're going to have something. Obviously, summer months, it's going to be more prevalent. Makes sense. You're at the beach, things happen along those lines. What states would you imagine would have the highest drowning rates?
Florida.
They're number 2. California's number 1. Any guesses on the third?
Alaska. Hawaii.
I thought it would have been Alaska because of the boats, the crab boats and all that. It's Arizona. I'm just telling you what I read.
Per capita?
Mm-hmm. And it's obviously more common on weekends because,
Swimming pools.
exactly, on weekends is when you're off and you're around the water. So, risk factors, all right? Poor swimming ability, all right? That's kind of understood. Overestimate swimming ability. I know when I was a kid, I would always go, when we would go to Florida, what's the first thing you want to do? Swim out to the second sandbar, okay? And more than once, by the time I got out there, I thought, that's a really stupid idea. And then risk-taking behavior, just like that. Alcohol and drugs. Like I just mentioned in that case that the lady had jumped off the boat. Here, hold my beer and watch this. Poor supervision. To this day, it never ceases to amaze me what people let their kids do just on their own. We're at the beach, you go ahead and do what you want to do. I watched it. And so low socioeconomic status is a risk because they don't teach swimming in some areas that they should. Hypothermia. How long does it take you for your heat to be lost, even in warm water? Not long. So you're impaired just by having the blood out of your brain. Acute trauma and medical issue. Like I mentioned before with the lady with the boat. That's repeated over. Or there was one not too long ago, I don't know if you saw Britney Spears' daughter, or sister's daughter. I used to practice over there. The only reason I know is Jamie Lynn used to babysit my daughter when I was, long ago. And her daughter rolled over on an ATV under very shallow water. The ATV rollover may not have hurt her, but being underwater for 3 minutes did. So it's very prevalent. Just being a male. Males are 4 times more likely to do something stupid than a female. I'm just saying.
No argument.
I'm not arguing either because I'm living proof. This is something I really found was kind of neat. How many people are divers here? Anybody watch the international free diving where they go down, they hold their breath, and they go? These guys are amazing based upon... Oh, am I too loud?
No, I'm just trying to make it so that they can see your slide.
Oh, mood lighting. Cool.
Yes.
So here, But in any event,
Turn off the board lights.
what I'm getting at is that in the old days, you'd see them and they would breathe. They had a breathing pattern. And they'd breathe in, and every different one had a different pattern. And you could identify them, like these French guys, I just remember, had a weird pattern, almost looked like chain Stokes. And they stopped doing that. And here is why. Because you have this red line is your PO2, okay? This is your PCO2. What is your drive to breathe based on? CO2, hypercarbia, very good. So here's the line where if you don't have enough oxygen, you're going to pass out. So normally you take a big deep breath, okay? And as you go underwater, here you're diving down, and your CO2 starts to come up like it's supposed to. Your oxygen starts to fall at a predictive level. And at this point, you have enough buildup of CO2 that tells your carotid bodies and your brain, take a breath. Okay? I got to go up. I'm air hungry. Okay? So as you can see, this is way above the I'm going to pass out line. Does that make sense to everybody? So when you hyperventilate before a dive, trying to do what? Build up your oxygen. Well, that doesn't happen because how much oxygen dissolves in plasma? Hardly at all. So all that huffing and puffing does no good. But this is what it does do. So your oxygen is still where it was, but look what happens to your CO2. You blow it all off, okay? So your PCO2 has gone down. So you go into the water, and by the time the oxygen still falls at a relatively constant rate, so by the time you get this trigger to breathe, what's happened? You've already reached, your oxygen has fallen so low that you're going to pass out. And they lost a lot of divers that way and had no idea until someone started doing the analysis on their blood gases and figured this out. So I just thought that was really something because I know when I was taught to hyperventilate, before I went deep. And we were taught this, and we were actually putting ourselves at much higher risk. So does that make sense? And I'm going to come back to this theory in just a minute.
And for the medical students, how quickly does the PaCO2 rise in centimeters of water per minute? 3, exactly. 3 centimeters of water per minute is how much your PaCO2 will rise in a resting state, slightly higher if you're swimming down. But the swimmers are typically weighted when they're doing that, so they don't exert themselves, so they don't use up so much oxygen and don't create quite so much CO2, but 3, so 3. And you know how you feel at 1 minute, so it gives you an index. And just what Dr. McGauly is saying is, a PaCO2 of 43 is really uncomfortable.
Oh yeah, you'll know it.
Yeah.
And the professional divers learn to ignore that, okay? They learn to ignore it a little more through every time to where they kind of hone it down to the point where when most of us would just come up for a breath, they can still stay down and do what they do until they know they're reaching this point. They're pros, they do it for a living, but they know right when they're getting to that point, and that's when they have to monitor how fast they can get to the surface. Because if they bolt to the surface, what happens? Because most of them are down 200 feet. They'll get the bends. Exactly. So it's not one of those sports for the faint-hearted, at all.
Since they're not breathing compressed air, actually, that's a misnomer. They can't get the bends because they're not breathing compressed air.
Well, if they come up too fast, they can. Now, they don't have to do the regular, dive table.
Right.
But if you come up from the depths that they're at, even if they don't have compressed gas, the gas in your lung is compressed at those pressures because they're down around 3 atmospheres.
Tissues.
Correct, already. I didn't know that until I went to the NOAA course.
That's awesome.
And I trained at Charity. We had multi-place chambers.
Yeah.
And we did hyperbarics for the DAN network all the time. In fact, just a caveat before I go on, the most interesting case of the bends I ever saw wasn't a diving accident. Two F-16s, whatever reason, were coming in at 30,000 feet, lost their canopies. So what are you going to do if you're at 30,000 feet in an F-16 with no canopy? I'm sure at a speed that's probably got your cheeks pulled out like a gerbil. You come down fast. They got bent. And they got bent bad. So they came from 30-some-odd thousand down to sea level, basically, 500 feet in seconds, and got bent really bad. By the time they landed, they could barely even fly the planes. But they survived. But the physiology actually of drowning starts with sort of a panic and loss of normal breathing pattern. Once you're submerged, and this is after you're under, you're going to lose, you can't breathe, so initially you're going to do what? You're going to hold your breath, okay? So you get breath holding and air hunger, and you're going to try to get, obviously, while you're conscious, your survival instincts are going to do what? Make you go to the surface, or try to. Your reflex, okay, is going to occur at some point. When your hypoxia, or the lack of oxygen at some point, that's when you're going to have a reflex inspiratory effort. You can't help it. It's parasympathetic. You're going to open your mouth. And what happens when you open your mouth? That's when some water comes in. So, when the water hits the back of the throat, what happens? The cord slams shut. It's a parasympathetic, autonomic thing. You have no control over it, okay? So once the water hits, now at this point you're probably semi-conscious at best. But at this point, it's mediated, water hits the back of your throat, and your cords do this, okay? Because you have now, I apologize, this is the back of the neck, this is the front, this is just the opposite. And I'm sorry, I just couldn't get them to work out right, but the visual was just too good to pass up. So you have your cricoarytenoid muscles here, and this would be here, and they slam shut, and that's the end point right there. Okay? Can't mistake that one. Once you have a parasympathetic surge, that's what happens. Okay? How much water, air, or anything is going to get into that? 0. So, moving on. So, during the reflex spasm and resulting asphyxia, because no air is coming in through there, right? So you're asphyxic. You get, as we mentioned before, in those graphs, remember? That's why I showed them. I wanted to kind of in your mind. Your oxygen does this, right? Your CO2 at 3 is doing this, right? So as the oxygen level falls to a certain level, you become so hypoxic, the laryngospasm releases about 85% of the time. We'll go into that in just a minute. So this releases. You're going to gasp, and water's going to come in, okay? That's when it reopens and water comes in. And we'll go over just how much and all the rest of that, because it's actually very important. And we'll go into the salt water, fresh water, cold versus warm as well. But ultimately, the survival, and every study has shown this, is directly related to the duration of the apnea. How long between no air and air, okay? And there was a physician in the Virginias, Semstrit, that started to work with paramedics for these drownings. And he got very well known with the military because what he advocated was, and this is before it became common practice, that if you had a drowning victim, the first thing you needed to do was what? Start them breathing, okay? Put a nasal trumpet in, an oral airway, a bag valve mask or your mouth, and start breathing. Because that was what led to the morbidity and mortality, was that distance. And we'll go over that in just a minute. So, just in general terms, aspirated water enters the lungs, which is obviously the target organ of drowning, right? It's the lungs. And so you lose the surfactant, which is the nice, slippery, slimy stuff that allows our lungs to move, be compliant, nice transfer, if you will, of oxygen between the alveoli and the capillary bed. It facilitates that. You lose that, okay? Salt water will be one way, fresh water will be another. This causes your lungs to not be as compliant, the ability to stretch them out and have air, okay? You get these perfusion VQ mismatches, the ventilation and perfusion mismatches, where they found on autopsy that Lunetta did, big study on autopsy of drowning, where 75% on average of your blood is in areas that are not being ventilated, okay? So you're not having any effective transfer of oxygen. Then you have vaguely mediated pulmonary vasoconstriction on top of that, so you're not even getting the full complement of blood, okay? And thus you get hypertension in the pulmonary bed. So you're getting resistance. As little as 1 to 3 cc's or milliliters per kilogram of aspirated fluid, and I'm not, all comers here, salt water, fresh water, causes significant gas exchange problems. So I have a slide, I think, with it in just a minute, but I'm going to preclude this. Think about the tidal volumes you put in a ventilator, okay? Just think about that. How many cc's per kilo on average? And you're already displacing that with fluid. So at least half of your tidal volume in a drowned victim, and 85% of drowned victims, is going to be what? Water. So, and it's not like you can literally stand a person. Remember in those days they used to tell you to do the Heimlich, or press on them, or turn them upside down. That water doesn't flow like that. You know, it's not really gravity fed. This water is going to have to get out of here, generally in your ICU, okay, over time, with osmosis, just, distribution. So what I'm trying to tell you is that this is going to take a long time to go. When you have a severely drowned person, you have a lot of fluid in there, and that fluid has to go by diffusion, and that takes time. So you have washout or loss of surfactant, you get fluid buildup in both the lung and the alveoli, and then you basically lose the diffusion between the alveoli and the capillary. Does that make sense? So, most drowning victims aspirate approximately 4 cc's per kilo. All right? That was from Lunetta, and that was a large study done at autopsy of drowning victims, because I can't imagine that getting through the IRB. And so considering your tidal volume of 7 to 8 cc's per kilo, half of it's fluid. Okay, before you even start, you're down that far in the hole when you get that victim, okay, and the trauma stat's called, you know, the ER is going to have to deal with this. But for us, I'm going to be passing that on to you. Here's where the art of losing that fluid and the tidal volume, the ventilator management, that comes the real hard part. And I have to say, you know, having done that actually for a long time, it's not easy. And there's all kinds of strategies we've tried over the years. Supine, they put you face down. I don't think any of them have really shown that, you know, there've been some benefit, but overall, not that stunning victory you're looking for. Go ahead.
Do you have any experience with the fluorocarbon and the liquid ventilation? Because that might have potential.
The liquid oxygen?
Yeah.
Yeah.
To allow the lungs to rest and heal.
The military was doing that in the 80s at the Naval Air Station in Panama, right? As part of Tyndall Air Force Base. Liquid oxygen is a two-edged sword. Yeah, you fill the lungs with oxygen. It takes a while for you to lose your drowning reflex, okay? In other words, they fill your lungs with liquid oxygen. What's the first thing you're going to do? You know, cough, aspirate. Takes a while to train somebody to lose that ability, okay? Second of all, your PO2 is so high, okay? They found that you lose your drive, the hypercarbic drive, because your tissue, your TCO2, your tissue oxygenation is like 1,000. You know, where normally it's, you know, 96%, you're off the charts. So you don't even need to breathe. And they've done some research in that, I know. I don't know the results of that because most of it isn't ever published. It's still, yeah, and most of it isn't being published, if you know what I mean. But there's just, what I'm trying to say is that the real hard work starts when you're a day out, 2 days out, and you're in the unit, and all the swelling starts, all the fluid shift starts, and I'll go into that in just a minute. But they also found, think about it, if some water goes into the lungs, what else relaxes? The esophagus, okay? So you get way more water going into your stomach and GI tract. So there's where your volume shifts start because you've just ingested all this water, both pulmonarily and through the GI tract. That's going to start some electrolyte abnormalities. Plus, remember, your PCO2 was initially high because you haven't been breathing, and you're become acidotic, right? So in the kidney, how many electrolytes are coupled? In other words, the sodium, potassium, you have the CO2. Remember all that stuff? I mean, there's a little brownout light kind of going off in the, for me, I'm farther out than you guys. You're smarter than I am on this because you've had it more recently. But the bottom line is you start having some pretty severe electrolyte abnormalities, and you have to stay on top of those or they'll get out of hand in a hurry. So continuing on, the final common pathways, okay, is going to be cerebral and coronary hypoxia. That's your primary insult, okay? Your secondary insults are cardiac, neurological, and everything else. But your primary, and don't forget that, is going to be how long the brain and the heart were deprived of oxygen. Because PEA is, as we all know, when you do ACLS and you hear that top hat thing, when you're in PEA, and I just remembered it as top hat, because in PEA all you can really do is what? Reverse the cause. Because PEA is so hard to treat. You can't shock it. You know, you can give some epi to keep the heart trying to restart. But by and large, PEA is the hardest thing to treat besides asystole, because you've got to fix the cause. And if you need oxygen in there, without giving oxygen, you're not going to restart. That's why the one change in, you know, ACLS is specifically to drowning, and that'll be coming out soon, I believe, is respirations are the most important, because now we just do chest compressions, right? And very little breathing, okay? That's going to change if it's a drowning, because drowning, your chance at life is pure oxygen, nothing else. So, aspiration, but mainly ingestion, lead to the osmotic changes and acid-base disorders that just throw everything out. And anyone that's managed a patient in the ICU knows when you start chasing acid-base things, whether you're lowering the vent rate, raising the vent rate, using bicarb, not using bicarb, when you're at that point, how hard is that? I mean, that's where you're sitting in that ICU and you have to stay there because it's a minute-by-minute change, and it's tough to do. So here's a little cartoon that'll go over what I'm going to go over even more. So that last involuntary gasp I told you about lets the water in, the vocal cord slams shut, okay? And then you have two types after that point. You either get a wet drowning, which is about 85% of the time, where you pretty much are on your way out at the time of drowning, true drowning, and your cords open up before you die. The water rushes in. 10 to 15% of the time, that larynx slams shut and doesn't open. Okay? So you don't have anything in there. Not oxygen, not water, not anything. The final common pathway being hypoxia, acidosis, and eventual cardiac arrest. And what happens after that? If the brain is so sensitive, if it doesn't get oxygen, it's all over. Okay? Does that make sense? All in like a nice little neat cartoon. So, dry drowning. By immersion, submersion, due to asphyxia secondary to the laryngospasm. In other words, it slams shut, no water gets in, it's over. Wet, water gets in, okay? And after the spasm releases, and you get some fluid in there of various amounts, the average by Luneta in their studies was about 4 cc's or less. Once again, 85% of the time you're going to have fluid, 15% of the time you're not. But remember, and this is where I kind of have my issues with the international definition, everybody drowned, whether you lived or not. If this all occurred, you're drowned. And so even if you get out of the water and you're resuscitated, you are not a near drowning internationally, you are drowned, but you survived. And I just don't think that gives enough characterization to the incident. In other words, if you survive the drowning, you're a near drowning. And I'm hoping that our nomenclature will prevail. So, sequelae, the acute lung injury, okay? ARDS, MODS, multi-organ dysfunction syndrome, easy for you to say, hypoxic brain injury, all right? Seizures, like, remember the case we talked about first? Infections, because people drown in a lot of things besides pristine. There was a case not long ago where a municipal worker fell into the who stirs, okay? And this one, whoops, fat fingers, became very prevalent, with aspiration pneumonia. Most of the time it's just chemical. However, if it's dirty water, if it's fresh water, pneumonia has to be considered infectious. So, salt water versus fresh water. All right, why does it make a difference? Fresh water they used to think that if you ingested the fresh water, because it's osmotically less active than your salty body water, right? The salty cells, that it would swell. All right, but you remember, you don't get that much. However, it's felt to be ingestion of the fresh water that really gets you in trouble in the long run. Most drownings, as we just talked about, are 4 cc's or less. To get any kind of major fluid shift, you need 11 cc's per kilo. Okay, or to get a electrolyte imbalance, you need about 22. So it probably isn't coming from the 4 in the lungs. It's the combination of the lungs and what you ingest. All right. So in the salt water, let me go back to this just real briefly. The salt water causes, because it's highly osmotic, lots of salt solutes. I liken it to, you know, when you were a kid, did anybody pour salt on a slug? And you saw the slug, the water just went. Maybe some people had more interesting childhoods than others. But anyway, or more boring. The same thing happens in the lungs. It pulls the fluid from the capillary bed, all right, and causes a very proteinaceous, thick membrane to form. And that doesn't go away, not very well. So generally with salt water, you get a scar and it stays. And your pulmonary function tests are never normal. Fresh water, the salt water, also just moves the surfactant. Fresh water dissolves it, okay? And it dissolves it throughout the lungs. So it's kind of like a lye burn, if you will, versus an acid burn. Acid burns are discrete, you know, wherever the acid touches, that's it. Lye burns, you get this liquefactive necrosis where, and the same thing happens in the lung with fresh water. It just washes it out. Your lungs stick together and they don't work after that. So fresh water can be a very dangerous place to drown. So warm versus cold. There used to be, and still are, some advantages where cold water, you hear these where kids fell in a frozen lake and they were in there for 30 minutes and they lived. Okay? No matter what, it's still survivability and morbidity and mortality is still dependent upon what? Duration, exactly. So even if the water's freezing cold, if you're there long enough, the chances of you surviving are pretty small. But here's where it does make a difference. So the definition of cold water for cold water, fresh water is 20 degrees. Okay? Pretty chilly water. San Diego Harbor is 56 degrees, and that was pretty daggone cold, okay? And I don't recommend people just doing that for fun, because it's miserable. That being said, you tend to lose consciousness faster in cold water. So what happens to the body when you lose consciousness? Exactly. Your oxygen consumption automatically goes down. So you have a little cushion, a reserve. Then your diving reflex kicks in, especially if you're a kid. Young kids have really hyperactive diving reflexes. Okay? So what is a diving reflex? It's apnea, makes you breathe much slower. Bradycardia makes your heart beat much smaller, or much slower, excuse me, not smaller. Probably smaller too, when you don't squeeze as much, but the bottom line is it's slower. And you shunt all the blood from the periphery to the core, and the core being brain and heart. Okay? So in other words, all the reflexes you would need to survive, and that whales and cervids, or cetaceans, excuse me, the family of whales, dolphins, and porpoises, cetaceans, they've honed these into where they can stay submerged, and some of the ursidae too, the seals and walruses, can stay submerged for a long period of time because they have learned and or however you want to say it, their lifestyle is this. They regulate their diving reflex. And that's how they live. So kids automatically go into this when they drown. Cold water, because think about it. How do you get someone out of SVT? Stick their face in ice water. Because what are you trying to do? Diving reflex. You're trying to do exactly that. Valsalva can do it because remember, you're going to hold your breath and bear down like a bowel movement pretty much when you hit that cold water. So the bottom line is you have a slowed metabolism, less oxygen required, and you automatically have the shunting of blood that you need to survive. So the degree of this is the survivability in cold water. Does that make sense? So here's a prognostic indicator, a little cartoon I found that was actually pretty elucidating. You have submersion for greater than 5 minutes, okay? Very poor. You have no resuscitation attempt in over 10 minutes. And that's, remember, I've reiterated that a couple of times from Semstrit's work. The minute they come out of that water, all right, you want to start puffing on them. Fixed and dilated pupils, that's kind of common sense because by that time things don't look so hot. GCS of less than 5. Remember our case that we had before. GCS is pretty much approaching that. So pH of 7.1 or less. Good prognostic indicators, okay, that someone may survive. Age less than 14, they had CPR immediately. CPR was successful in under 25 minutes of getting ROSC. A detectable pulse on arrival, and a core temp of less than 35. All right, so here you've basically already started the hypothermic, the therapeutic hypothermic, hypothermic protocol all on its own. Sir?
So, is dry drowning, I mean, does that have like close to 100% mortality then?
Not necessarily. Because if you can bring them out, supply some oxygen.
But I mean, they're still in spasm.
Exactly. And if the spasm is there, there's nothing you can do about it.
Unless you do a trach or something.
Correct. And so, that's a consideration as one of the last ditch efforts, if you will, and you have to make that ethical call in your mind. If they've been down an awful long time, are you really going to be doing them any favors?
Then when you talk about that, the duration of the apnea, I guess it's just your luck, because I mean, it's at that point, the laryngospasm happens, it's going to get released based on the O2 and the CO2 levels.
Right.
And so every person is different, so I guess based on your sort of system, the duration may vary.
It varies, and how soon, that's why that they want you to bag them, the first responders. When you pull someone out of the water, start the respirations, because that's their only chance at life. I mean, yeah, you're going to start CPR because their hearts, if they don't have a pulse and all the rest of that, but with drowning, oxygen is the key. Because once they start getting oxygen, that was the insult, and it'll start kicking in, hopefully. But you're right. I mean, it's all in how long, if someone gets to you sooner. I remember when I was a kid, a teenager drowned in Florida when I was there, and I just remember seeing them under the water, I was watching them, and, you could see them like under there, and it took them forever, it seemed like, to get him out, and I thought, that's really stupid, why aren't they hurrying? And now, in retrospect, I should have run in the water myself and pulled him out. But I, was just a scared kid, and plus I was kind of wowed out by, there's a person under the water. It's not every kid sees a dead person, but anyway. So, long-term prognosis. 35% of pediatric immersion episodes are fatal. So about a third are going to die. It's even higher for adults, okay? It's up to 60%, all right? 33% will have some long-term neurological impairment of some sort, either cognitive issues, motor sensory issues, and 11% will go on and be severe, okay? So these are obviously going to be permanent care patients. And then 60 to 100% of the adults, all right, are going to have some impairment. So kids fare a whole lot better, but it's still high that you're going to have some form of impairment. So, depends, remember this sound familiar? The injury is going to depend totally upon the duration. There were 3 or 4 studies, retrospective studies, that looked at that, and they have a linear curve. The longer the duration, the worse the sequelae. Hand up, or are you just stretching? Cold water drowning. Remember, you have some beneficial effect because the water temperature is low, especially when it's really low, like below 5 degrees, because when that happens, your diving reflex, remember we talked about that, and the fact that your O2 requirements go way down. Less than a 5-minute submersion, and if you're very young. If you're below 8, you have plasticity, you have other things, but the diving reflex is very strong, and they tend to have better outcomes because of it. All right, pre-hospital treatment. Remember, before anybody moves anything, if you become a casualty, you've just doubled the work on everybody else. So make sure that the dangerous situation is neutralized, okay? If there's a power line in the water, what good is it going to do for you to go out and get electrocuted? None whatsoever. And that's very hard to tell people not to do something like that, because your first instinct is to what? Jump in and go fix it, especially if you're an EMT, because those type of people, that's hardwired into their blood. Removal from the water, okay? Remember, if they dove into the water and it's shallow, don't be pulling on their C-spine, okay? Maintain that C-spine, because it does no good to do really great resuscitation if they have a C2 or a C1, fracture dislocation, and they're dead from that anyway. So clear the airway. Remember, there may be vomit. How do you do that? Rescue position. Remember, back in those days, you roll them over onto the left. Key is breathing and ventilation. Get an oropharynx or nasopharyngeal airway in and start bagging. If you have to puff, puff for them, okay? Highest oxygen delivery possible initially. We're almost done. Begin ventilations immediately, all right? At least 2 before you start the CPR. Do not wait. If you can't get them intubated, fine, start bagging them anyway. Assess cardiac status and CPR. If there is no pulse, go ahead and start it. Follow your BLS and ACLS. But remember, most places also, and I tell you these things because some of you guys at some point are going to be involved with outpatient hospital EMS, and I want you to know what to do, okay? They carry comba tubes and King Airs. You don't need to stick the ET tube down. King Airs, you just put them blindly and inflate them, okay? Emergency department, all right? Definitive airway. Remember, what's the ultimate cure for all of this? Oxygen, okay? And to answer your question, if they have that spasm, sometimes even then you're able to get the ET tube past it. Especially if you use the bevel and push it. It's a little technique that sometimes they'll open. If there's any severe signs, seizures, sequelae, any of that, go ahead and intubate them. Make sure your tidal volumes are relatively low. You may need to use PEEP. And you can consider, for those that are awake and will go along with you, BiPAP is awesome for this. Okay? start to go down on your FiO2 as soon as you can. Why? Because you get the free radical, you can burn these people with too much oxygen. All right? And then no benefit from just prophylactic antibiotics unless it's dirty. If it's real dirty, give them antibiotics. So, you want euthermia, want to warm them. Post-arrest hypothermia, if they're already cold, leave them cold, is the recommendations. All right? Make sure that you hemodynamically, because remember, these people are going to get dehydrated. Remember to give them the fluids, okay? At labs, x-rays, and then you're going to need, oh darn it, I keep doing that. You're going to need an initial set of lights because you want the electrolyte balance and the acid-base balance as well. I manage a EMS system in DeSoto, and we're putting point-of-care gap analyzers on our ambulances. So pretty soon when we show up, we're going to hand you their first set of electrolytes and lactate. Think that's handy? So you know where you start. I just thought it was that important to know as soon as possible. So, asymptomatic patient. Generally, make sure you use a chest x-ray that they don't have any atelectasis forming. 4 to 6 hours observation. Mildly symptomatic, they have cough, some wheezes, go ahead and admit them for OBS for 24 hours. The studies have shown, though, especially in pediatrics, that if nothing has shown up in 7 hours, nobody had symptoms after 7 hours if they didn't have them before. Severe symptoms, respiratory distress, that sort of thing. Remember the case that we had? Full ICU admission. ACLS, that sort of thing, consider ECMO in these people. All right, and we are an ECMO center. So here's that same thing in a cartoon form. And then admitted patient goals, okay? It's all about the ventilatory support, all right? And hemodynamic stability, maintaining those. Monitor for the ARDS, the pulmonary infections, that sort of thing. But it's all in how well their lungs work, and it's all a respiratory, ventilatory thing. So real quick, you can't answer. So what's the priority in that first case? Kid came in and his SATs are low, and he's seized and maybe posturing. Exactly. So what are you going to do? Absolutely. So what did we do? Intubated him right there. Secondary goals. What was next after we started the ventilatory?
Check his vitals. The rest.
Maintaining, you're right, maintaining his saturations and that sort of thing. And then once he was extubated, once they're moving along that curve, what's the next step? Begin rehab. You know, make sure, see what they have left, where you have to go. Begin the rehab process, you know, from there. So, but we had this case, what, last week?
Yeah, something like that.
Kid did well, I understand. So, anyway, any questions or anything?
I have a question for you.
I know the answer.
Mental status, when they, so you can, if they've got a heart, if they've got a pulse, if you can get a pulse back, and being an ECMO center, we can get them back to where their lungs will be functional most likely. The question is, at what time point, whether it's presentation to the ER, from out of the water to what time point can you really sort of say, okay, this is what their neurologic, this is where they're going to be, in that if they've got a GCS of 3, saving their lungs and turning them into, you know, perfect vegetable
Isn't the right thing.
Right, it may not be right.
Or you can look at it too, you know, maybe it's an organ donor at that point, because these are usually young people, not as sick. I find personally that a saving thing to me. Like if it were me, I would hope someone would get use out of an organ. I don't think one old organs like on, but I'm just saying that if it were my child, you know, I would want them to live on. But as far as ECMO goes,
Or really the question is the neurostatus. Is the neurostatus on presentation, is it what you see is what you get? Or
No.
do you find in some of these that they come in and they're still sort of in a sense in the throes of their diving reflex?
Correct.
And that what you see may not necessarily be their best GCS.
we'll use this
That kid,
case.
he looked horrible.
He looked he was
Wasn't
posturing
responsible,
on presentation, had a crappy sat,
Okay.
and so we intubated him, and then from what I understand,
Extubated and.
within 2 days he was extubated, and I heard he's on the P's floor and he's fine, or he's gone now maybe. But he did fine. Where when he first showed up, his GCS, you know, was 7.
Right.
And the air crew was all kind of upset that we jumped on it that fast, you know, like they felt they had missed something. And, you know, conditions change, you know, and I told them, I was like, I don't know if it would have helped you to have intubated him before. I probably would have. You know, I don't play with this because I can always pull a tube. It's really hard to do it in the back of an ambulance or, you know, in a helicopter.
Yeah.
So condition, situation, it's all part of it. I probably would have intubated that kid in retrospect, have told them, hey, you need to intubate that kid at the scene. Hindsight's 20/20, but this young man didn't need ECMO, and he was pretty much normal. Am I right? And I would, and with a GCS of 5 at presentation, I would have never thought
No.
at all. I thought we were looking at an organ
It's
donor.
not necessarily what you
No, especially not in kids.
Yeah.
There's another question? Yes, sir.
I have a comment and a question. Number one, as a cardiologist, not all drownings are drownings. Don't forget things like lung QT syndrome can be triggered
Very
by
true.
swimming and can cause sudden death while swimming. But number two, my real question, has the use of recombinant surfactant been looked at in these drowning patients to see with the surfactant disruption if that would be beneficial?
I did not look into that. I do not know. I would imagine if, you know, usually if you thought of it, somebody else has, you know, that kind of thing. I would imagine so, but do I know? I don't know. I don't have any personal experience with it. You know, I've never seen it used here, to my knowledge, for that purpose. But it's a good point. Yes, sir.
2 comments. One about the ECMO. Basically, if you go to ECMO, you're using it because you can't ventilate them.
Right.
You know, and so I think by the time you ventilate them, got them intubated, and do some respiratory support, you know if they're going to get better or not. And by the time you know that they can't be ventilated and they're extremely hypoxic with ventilation to think about ECMO, you probably have to worry then about your neurological recovery. So I think if you got to the point where you really were thinking of ECMO, I think, you know, that hypoxia has been sustained. So you've got to be worried about that. The other thing is when they do rehab, don't forget to educate. It doesn't help if you save a 2-year-old and the family doesn't go back and cover up the pool and he goes out and dies the next week. So you really have to educate these families and kids about preventative care and to avoid those types of things in the future, because a lot of times you see there's 2 other 2-year-olds running around in the neighborhood, and if they keep filling up the bathtub and walking away, or if they don't put a cover on their pool or lock the gate.
And I don't know, how old was the kid that had his
16.
hands
16 months.
taped to the ATV that then flipped over into a puddle of water or into a body of water? And because they didn't want him to fall off, they taped his hands to the, and then,
That's a Darwin Award.
That
Yeah.
I
That's
mean,
horrible.
well, that's
terrible.
Is that here?
child.
Yep, that's one of ours. That is.
I mean, that's one of those things where, you know, as far as the parents go, the stupid gene has definitely passed.
Yeah.
That's criminal.
Yeah.
I hate to say it like that, but that just, is beyond
Yeah,
the,
it blew my mind. I just was
Would
trying
never
to
occur
get
to me.
around
They just brought
taping,
it.
and the kid
So
was
include that
below
in.
2, I think.
Don't speak.
unbelievable. Well, thank you all very much for